Good afternoon, everyone. Thank you for joining us today. Today's webinar actually wraps up our RHC series that we had planned and started, I believe, in January of this year. And so this is kind of I wouldn't say capstone, but it's kind of our summary and let's answer any questions you might have. We have a panel discussion today. Amy Graham is leading and moderating. We have Opal Greenway as well as Kate Hill sharing updates and answering any questions you might have. With that said, we're a small group. Please feel free to unmute your own lines, send a chat, send an email, send me a text if you want, so we can get your questions and discussion included. With that said, Amy, I will turn it over to you.
Thanks, Laura. I appreciate it. We are just going to do a recap looking at some of the different main topics and key takeaways from a lot of the presentations that have occurred this past year, as well as we've received some questions from the field. So thanks for having us, and I'm just going to jump right in. The first question we actually did get from the field was this person would be interested in hearing a discussion around the factors regarding financial feasibility in regard to participating as an RHC. Some specifics would be nice in what factors, scenarios, patient mix, et cetera, exactly is looked at in doing a feasibility analysis, and how much time, man hours approximately does a participating as an RHC cost a clinic, full-time provider, pros and cons of being an RHC, and then talking about the patient mix. And that actually really worked well with feeding into a presentation that Zach Bozer did for us on just determining financial feasibility. But Zach's not on the call today, so Opal, I'm going to hand that over to you. And if you need me to go back over those questions for you, I can do that.
Well, thanks, Amy, and thanks everyone for joining us. So when we think about this from, the path to certification, right, the reality is setting up an RHC initially, it's a lot of paperwork, right? Of course, a government designation is going to have a lot of paperwork to it. And so in doing, when you're starting out and going through and doing your feasibility assessment, just understanding, can you qualify as an RHC is important, of understanding what are the location requirements for the program. Is the physical location that you've selected, does it meet those requirements, right? Then, of course, we recommend doing a RHC financial feasibility assessment to understand, hey, is this actually going to be financially beneficial for you? In pretty much every instance that we have gone through, and pretty much is going to be financially beneficial to you. Not quite as much as it was before we had that regulatory change as far as what's going on for reimbursement, but it is pretty usually financially you're going to be better off as an RHC, but as opposed to a freestanding clinic. And so you're going to go through to perform your financial feasibility assessment to understand whether or not it is going to be actually in your best interest. Usually the answer is yes. There's an RHC application through the state and from the CMS provider enrollment form that needs to be filled out. If you are eligible to participate, after you fill out the form, you receive notification and undergo a specific survey inspection to ensure that your clinic's in compliance with all of these different requirements. You can go through, use it done by a state agency or another accredited organization to actually do that survey. We typically recommend anytime you're getting ready for survey, just because of the amount of effort and time it takes to be able to do this and all the documentation associated with it, is to go through some sort of mock survey to make sure you have all of your I's dotted, your T's crossed, boxes checked before going through that survey process itself. Once you complete a survey and get successful passing it and demonstrate that you're in compliance with the RHC program, the surveying entity will recommend your clinic for the certification approval to CMS, and you receive your Medicare provider letter, and that allows you to officially operate and bill as an RHC. So now you can actually establish your Medicare and Medicaid rates. So all of that piece, I go through that entire certification steps, and Kate can provide a lot more detail, especially because she is a certification expert. Is when I think about how much actual extra time does it provide the clinic on a per provider basis operationally, once you have that actual designation, I don't actually see with the providers I work with them it increasing the man hours as a provider from what I consider top performing actual clinics. because what of the RHC, when you think about the pros and cons of maintaining that RHC status, besides financially, a lot of the things that they look for in an RHC actually help your clinic operate better as a clinic to begin with. So as opposed to a freestanding clinic. And so there are some significant pros in the sense of all the different checklists that they put in place for you for an RHC compliance are things that even if you weren't an RHC, I would go and tell my freestanding clinics to do to be, to be able to perform at, best practice. So it really helps the clinic that is thinking about population health and is trying to do some overall, like especially chronic care management and all of those different pieces. Going through the RHC process operationally can be one of the things that helps you get your ducks in a row to move yourself forward in clinical integration, into care coordination, into a better chronic care management program, even if you're like focusing on it from a, hey, can this help us with our opioid epidemic? And doing treatment for that in a primary care clinic. So I would say that the pros significantly outweigh the cons from an operational standpoint. The cons, of course, being that there's two that come to mind. One, paperwork, right? Like there's certain things that you need to actually make sure you're doing and checking those boxes, and the fact that you need to meet your minimum provider, so your visit thresholds for your providers each year, et cetera. Those thresholds are actually pretty low. So from what we consider best practice of like thinking about it from a patient throughput. So I wouldn't really list that as a con other than you have to make sure it's more paperwork. The other con that I know we're going to talk a little bit about revenue cycle later in billing and coding is I have seen some RHCs, because they get used to the documentation for the RHC, kind of slip on their documentation on the commercial side of things, because you're used to an all-inclusive rate and a visit is a visit is a visit. They kind of slip on some of the documentation of what would distinguish something from a 99214 from a 99212. And so, those are the pros and cons that I see from an operational and a provider standpoint. Kate, I don't know, given your certification expertise, I don't know if you have something that you would add to that.
Oh, we don't do on that billing side, so no comment from here. Thanks.
Yeah. Oh, sorry, Kate. I was talking about on the clinic side, like as far as overall as a clinic, if you saw other differences in pros and cons.
None that I can think of at the moment. Thanks.
I would say, Opal, the one thing that for Oklahoma that is a factor to think of from a pro standpoint is that the reimbursement that the Medicaid Oklahoma follows, because when an RHC certification happens, it will impact both Medicare and Medicaid. They both recognize that status. And so your reimbursement rate for Oklahoma follows in line with what your reimbursement rate is, or for Oklahoma Medicaid follows in line with what your Oklahoma Medicare patients would receive. So that, you could be seeing additional payments just based upon what that rate is, and showing that, right now in 2022, the reimbursement rate is $113 per visit, but by 2028, that rate will go up to $190. So when you think about the amount that you would be receiving from both the Medicare and Medicaid patients, financially from that perspective, I can see how that would be a pro for the organization. But as you said, we'll talk about it here in a minute, is just the revenue cycle challenges that are going to be faced related to it, and helping them understand that they're financially helping the organization. All right. Well, let's go on to our next question. So Kate, you did an RHC Compliance 101 presentation for the group. And I know that since that time, there have been some top 10 deficiencies that you're still seeing since that presentation, since it was one of the ones in the beginning. Can you talk to us about the top 10 deficiencies that you were seeing in the RHC clinics?
I would be delighted to do that. So only one new one on there, and I'll hit that when I get to it. But the biggest problem in the last 2 years is open and dated single dose vials. Now, I know if you're clinical and you're on this call, you're rolling your eyes, because as a nurse, it makes me roll my eyes. And I've beaten it to death with teaching and I'm still finding it. So please get the word out that single dose vials cannot be dated. They're once and done. And if we find it open and in the shelf, dating is a failed survey. Failed, and that came from CMS. There's no chance for error on that one. But if it's punctured, if the top is punctured, we're going to ask a lot of questions, and it's really not very pretty. It's unsafe practice medication administration. So let's hit that one hard, and then we'll move on from there. So on number 2, lack of documented chart review for the NP and PA, that is not mostly you're not that you're not doing it, but you have no way to show the surveyor that you're doing it. So it's easiest to keep a log, or if your EMR will pull up cross-sign, that's fine. One way or another, you have to prove to the surveyor that you are doing that chart review and that the number of charts you're doing matches what your policy says, unless, and I apologize, I didn't check, unless Oklahoma has a specific number, and many states do. Number 3 is incomplete review of emergency preparedness exercises. I should have added or events, because what happens is you've lived COVID. Everybody's lived COVID for 2 years, and that's a perfect event to write up how you handled this emergency. But they forget to do the evaluation of it. Here's what we did. Here's what we learned. Here's what we do better next time. That kind of thing. It's an important piece of that emergency preparedness. It is not a failed survey, certainly, but it's a deficiency. Improper sterilization of instruments can go both ways. We had a really awful one on Friday with really, they were not sterilizing their instruments, even though they thought they were. The process was really bad, and we had to fail that clinic. That's a big, you want to be 100% sure when you hand an instrument to a provider that it is sterile. My goodness, that's basic medical information. So let's go out and make sure. Now, if they're using a tabletop sterilizer, it's almost always a deficiency, because here's what we do. Let's pull the manufacturer's instructions for use for that unit. And then we'll see what you're supposed to do to keep this working properly. And they're never doing what that says. So that's a real problem. So make sure they're looking at that. Disposables are obviously the best. They're also the most expensive, so there's lots of ways to do it without that. Expired medications goes without saying. You got to check all the supplies and medications once a month. Anything that has a date, inevitably there's some things on the sheet, and if there's just a few, it's rarely a failed survey. When the entire emergency box is expired, we might fail that survey. Now, the new one is lack of COVID vaccine policies. So we had a clinic about a month ago, 100% vaxxed. And so they thought they were fine. They didn't need any more policies. Well, that's the failed survey, because that CMS is very adamant about that we will have the policies that they direct at 491.8. Number 7, the signage on the door does not match what you put on your 855. So you're representing yourself to Medicare, something different than you're representing yourself to your community. And that doesn't work. And so that would be a deficiency for sure. We'd have to get either the 855 updated to what you're calling yourself, or change the sign on the door.
Hey, Kate, before
Yes.
you move on, I will say one of the a question is with regards to that requirement as far as the signage. One thing that I've seen when I'm doing a lot of operational stuff with clinics, including the RHCs, is that what you see on like Google, you know how when you go onto Maps and you look up a location, it'll tell their times that they're open.
Right.
So what's online, what's on Facebook, and what the door is on the door doesn't match. Do you see that, and how do you make what is the actual requirement of what has to match your 855A form? I mean, obviously best practice would be of course having them all match, but is there a specific one that has to match the 855A?
Well, that's a great question, Opal. There's 2 names on the 855, the legal name and the DBA. We're good with either one. So as long as one of those appears on that door, on that Facebook page, on that, in the paperwork in the clinic, we're good. But it's one of the 2 for sure.
Okay, great.
Yeah.
Kate, I think that's really fascinating about the 855.8 and the reported name, because if the name that you bill under does not match that 855A, then chances are Medicare is not going to pay for that claim. Yeah, they'll reject it because they can't identify the provider. And so it's really key. It is a form that you fill out once back at the beginning of time and no one never really thinks about it again, but it is so critical. It's fascinating to see that.
It's hard to believe it's on the top 10, isn't it?
It
really
is, but I get it. Makes perfect sense to me.
Right. So updating your 855 is not you don't have to do the whole form over. If you're doing in Pecos, it's very easy. It's updated information. So if you add a suite, if you add a whole new service, or if you change your name, make sure you go and do that. Medical director is updated on the CMS 29, which goes to your creditor and the state. Okay, number 8. Missing consent to treat. So it isn't that you didn't get your patient to sign, but it's not entered into the EMR. So many clinics have a system where they have a patient sign a piece of paper, which is a consent, and then somebody has the job of scanning them in, and that often does not get done. So we want to make sure that's happening. And then number 9, your policy does not match your process. This can come into play in so many areas. Just happened. A clinic decided they were going to do their biennial evaluation every year, which is fine. But they didn't do it last year. So we surveyed and they have to match the policy. So even though the federal government required it every 2 years, their policy said every year. So it was a deficiency, not a major deficiency, just standard level, but still. So let's check chart review. The number of charts you review is 10 per quarter, and you only do 5. So it's that kind of thing. You've got to match what you're saying your policy says. And number 10 is incomplete HR files. I can't tell you, and I don't mean to call out the independents, but it's hardest for them. They don't have an HR department behind them at the hospital. So they often miss many things, annual review, performance reviews, hepatitis B inoculations, or a declination, either one works, but all kinds of things in that HR file are missing, particularly for the independents. And that's because you have this full HR department doing all the work. OIG exclusion database, once a year, every person that works in your clinic must be run through that to verify that they don't have some job somewhere else and they got into that company got into a little trouble with CMS, because once you're on that list, you have to petition to get off it. So that's a problem as well. And you cannot you cannot hire anyone on that list. And that is the top 10. Any questions on that or other questions?
Well, Kate, I do actually, I have another follow-up question for you. I was thinking about when you're talking about, these, your improper sterilization of instruments, but then you talked about your policy not matching your process. Do you have any tips or tricks for anybody for, how frequently or how they should go about making sure that they have, their policies and their practices are all matching? Like, is there a certain frequency that you recommend people, especially with all the staffing changes so many people have had and not having time to properly train staff? Like, is there a proper frequency that people should be doing this, or a way that you would recommend people tackle that?
Well, the federal government requires the policies to be reviewed every 2 years. And so that's the place to start. And anytime you change a process, like let's do a complete review right now, make sure we're doing it that way. And then anytime you change anything, go to that policy and update it. And that's the best advice I can give you. We did a policy review at the compliance team in March, all our policies. And there were 3, I specifically remember this, that we aren't doing it that way anymore. And so we fall victim of this too, because you get so busy doing that you don't look back to the policy. So at the minimum every 2 years, and certainly for any updated. So right now, your emergency preparedness, your infection control probably changed in the last year. I don't know when you did your policy review, but you want to go and check those. And the people that need to read the policies are those in that sphere. So maybe the provider doesn't need to read that. Let me think, emergency preparedness policy, although we should, but other people that work in that space, maybe the CNAs need to reread that number 1 deficiency. We had a CNA with 4 single dose vials dated in the closet. This came close to an immediate jeopardy situation. She said to the surveyor, "I never knew there was a difference." So how many patients got ineffective or harmful medication with something growing in there. So really, really important. Don't assume they know, really, really seriously. And so if she had read the policy, which included that, she might have caught that. So it wasn't covered in her training back in CNA 6-week course, not CNA, MA 6-week course. That's a definite distinction there. All right. Does that answer your question, Opal?
Yeah, that is. Thank you for that, Kate. I think that's great.
I could go on forever. So I'm good if nobody has any more questions.
Well, great. I think, Amy, the next, I know we had a session was specific to the RHC coding best practices. And I know I mentioned briefly when talking about the things that are different for an RHC with regards to, what's going on with commercial versus your UB4s. So what do you see as the biggest challenge when it comes to that billing and the coding for the RHCs?
Thanks, Opal. Honestly, the thing I see as the biggest challenge for coding is that the commercial plans make no distinction between an RHC and a physician-based practice, whereas the government plans do. And that really causes a lot of angst with just trying to get the bills out. How do you know what information to put on the claim, which claim form to use? Just how do you identify that information? Because, physician practices are used to billing on a 1500 form. That's how they do it. But when you come through with the RHC billing, you bill all of that information on that UB form. And it really does cause some just, okay, what do we do? And if your staff is turned over, how do they know how to follow up on it and make sure that it's being done right? Just this past week, I had, one of the billers and coders call me and be like, Amy, how do I know which plans, the Medicare Advantage plans, they should be following the same rules as Medicare, right? And I'm like, yes, they should be paying you your all-inclusive rate for qualified visits. However, how they want to be billed is how they want to be billed. And those are the rules you have to follow. And I wish that it was consistent amongst payers, amongst the commercial payers, but it's not. And so you have to identify for each of your Advantage plans, what form do they want to receive? What format do they want a specialty code? Because they could be certain Medicaid plans want you to include a T code instead of a CPT or HCPCS code, which is totally different from the way Medicare wants you to bill and any other commercial plan out there.
Now, Amy, one of the things that we've seen is, especially a lot of our hospitals might outsource their billing, right? Like,
Yes.
a lot of them will use some sort of third-party vendor, and they'll do it maybe even for the whole hospital, or we do have clients who do it just for like the physician clinics. What are some tips or things that you would recommend, given the fact that RHCs are different? Like, do you think third-party vendors are doing a great job with the RHC billing? If, how does a hospital keep a third-party vendor compliant, in check, making sure they're doing their best as far as the RHC billing, given that it's different?
I will tell you that is one of the areas that I'm finding that it needs the greatest amount of training. That you've got some clinics out there or some third-party vendors who are doing the billing who really understand it. They're on top of their game, they know it. But I would say they're in the minority, not the majority. I do a lot of education with those outside billing companies, just helping them to understand the rules and regulations. And I'm doing it in partnership with the clinic itself to say, this is how the claim needs to be billed. These are the rules related to RHC. Because when you think about it, your RHC business is a subset from a critical access hospital business, which is small compared to other businesses that those billing companies may see and may have. And so when you look at the work that's there, what you want to make sure of is that overall, when you are receiving your payments for your RHC visits, that you are getting the Medicare all-inclusive rate. That if you know you're supposed to be paid $113 per qualifying visit, that you are indeed receiving that $113 per qualifying visit. And it would be relatively easy to ask your billing company, your third-party vendor, to run you a report that says, I need to know how many Medicare patients there were and what my average payment is, and to see if you're getting that $113 per visit for your Medicare patients to begin with, and then working through your Advantage plans as well. So yeah, just consistently following up with them, making sure that they understand that for qualifying visits, you are getting that all-inclusive rate, and for your non-qualifying visits, that they may be paying based upon a fee schedule or percent of charges. And so you want to, just monitor their activities, making sure that they're not writing the contractuals off, following up on them on just what are the contractuals they are writing off for on a monthly basis, and how does that look compared to the overall revenue, and are they getting that payment being received?
That makes a lot of sense. Yeah. I mean, I don't know, Laura, if you know how many people or how many people on this call are using a third party to do their billing, or if we have any idea of how many of the ones we've worked with in Oklahoma are using a third party.
It's interesting, that question, Opal, because there was a recent study that was released that said I think it was around the number of 60% of hospitals that were surveyed said that they outsource a portion of their outpatient work, not the inpatient work, but their outpatient billing services revenue cycle services were outsourced to a third party. And so when you think about that the work, that your revenue, your RHC is considered outpatient business. And so what does that look like, and how can you really monitor that? And I will tell you that, key performers, top performers that are out there are really making sure that they're staying on top of claims that have been billed. Are there any rejections? How they're monitoring those rejections and such. So
Well, and I bet, and so Amy, that number you're talking about is for hospitals, but in my experience, anybody who's an independent RHC almost always is using a third party.
correct.
Very few physicians do I know of that are actually doing their own billing, even in an RHC. I mean, it's very complex for somebody to be able to stay on top of themselves.
Okay, that's perfect. So, Opal, I think the next question for you is for you. So I'm going to toss it back to you to say, what are some workforce staffing options that are out there for the clinics? That we talk about outsourcing some of some of the revenue cycle pieces of it, but how do we address? You can't really outsource the clinical work. So how is that handled?
Yeah, I know we had a presentation about RHC financial and operational best practice, and we talk about some key attributes of top performers. And here's just a quick for everybody to have some key takeaways that were from that presentation about financial and operational best practices. But the question that keeps on coming up now, right, is, regardless of financial and operational best practices, we've gone through COVID. We can't get staff. We're in an unprecedented time with regards to actual staff. And so I put together another slide actually about operations and staffing and what to do about the fact that you have to work with what you have, right? Oklahoma is a restricted practice state when it comes to utilizing APPs. And, thinking about that is how you utilize your physicians and your APPs together. What can you do to utilize staff at the top of their license, or what is allowed in your state, or frankly, what is allowed under your payer contract, to be able to utilize staff the best you can. So something that I've been thinking about a lot, and have actually worked with several of practices, including practices that are on this call, as far as how do I deal with the staff that I have right now, is you've got to look for waste. Right. You've got to be like, what do I have that I don't need to be doing anymore? And, if that might be, hey, we have a previous policy that said this was the case and we haven't been following it anymore and we need to update it. That includes hey, maybe it's time to go back and look at your processes and be like, are we doing all of the processes that we actually need to be doing? Or are there things that we can cut out? So one of the things that I've done with a lot of practices that anybody can do is to do a time motion analysis, is basically have everybody in your clinic just, not at the same time, but monitor how they spend the next 30 minutes, right? And do it for a few weeks, do it, a couple of times, pick a couple of days, hey, Tuesday at this time, this Thursday afternoon, the following Monday, just random times to monitor for 30 minutes as you are doing your work. Just do a little quick, post-it note or whatever of tracking how you're actually spending your time. And so I have on here an example of doing a time motion analysis for a physician. And so that physician and we did it for 33 minutes, not 30 minutes, because it took a little bit longer to dictate the chart and we timed that, of what the physician was actually doing, and recognizing, okay, if we look at all of the time that was spent, what is, and in this 30 minutes, what is stuff that is absolutely critical that the physician do versus what could actually be delegated versus what is just, in the sense, in wasted time. And you're like, well, some wasted time you can't necessarily get rid of, like walking to the lab, right? Like there's certain, taking steps to move to something else that's not, you can't necessarily get rid of it. But you look at those 30 minutes for each member of your team, and you start, and that's one way to identify where is the waste, what are the things that are happening that are creating bottlenecks, whether it's an excess of process, a lack of process. So, this is also how you identify where you might be missing, properly sterilizing equipment, or doing one of the things that, Kate was pointing out that is a top 10. But how much of that is actually wasted, or is, especially the biggest thing to me, is there something that you are able to delegate to someone else that is more appropriate and effective in your clinic? And so if you actually do this, like we always start with the top license first, is we do it with the physicians, and then we do it with the nurse practitioners, and then going through there, because it helps us identify who we can delegate work to, with recognizing, hey, maybe we can't, since we can't get additional staff, how can we reallocate responsibilities to people, one, who might have the time available to do it, two, who it's part of their actual responsibility based off of our processes, protocols, and job descriptions, but also maybe is there somebody who is more apt to do it, who can do it more efficiently? And if there is somebody who does it more efficiently, what is their process for doing it that way? Why are they so efficient? Is it just years of training, which oftentimes happens with some of the nursing stuff? There is our nurses who have been working for 20 years are completely invaluable about just the things that they do second nature, that needs to still be trained to people who might have just come out of school. But there's other things that, hey, it's because they figured out, here's the best way of doing it. Here's a training opportunity in our EHR. Here's how, here's an opportunity to automate something, such as the fact that, like, doing patient reminders, the amount of time, like, we usually don't want to spend the money on doing an automated system for patient reminders, but that is something that when we can't get the staff, that we're in the situation right now and we're so short staffed, what can we actually delegate to an automated process? And so going through that little exercise of a time motion analysis is one way to really identify that. We've seen that with a lot of clinics who've been like, hey, maybe I can get away for it, not the fact that I can't get another FTE, another body to be able to do this, because I can reallocate this time to these other people. So that's something that I would say, when it comes to the staffing, this is something that I would have everybody basically go through. Especially because you can do it on your own and be able to identify, especially as a practice manager, have everybody in your clinic do it, and it's very data driven what you're going to adjust based off of this.
Thanks, Opal. So talk to me about how do you understand what the options are for a care delivery in an RHC? So you're looking at these staffing options and doing the time motion studies. If we switch it to another side and think about what are the options for care that we want to do in the RHC, how does that look?
So the way that I look at it is, starting out with, realistically, what does your community need, right? A lot of all of us who have, that we've done work with in Oklahoma, they have to do what's called a CHNA, a community health needs analysis, and a lot of times that is posted on the website, and it's used to be able to check the box with the IRS because it's a requirement to be done every 3 years. But realistically, the CHNA can be used for so much more than that. And then what I like to use the CHNA for is really figuring out what is the appropriate complement of providers that I need in an area. So if you think about your RHC, you always think about it from primary care, but a lot of we've worked with a lot of you in Oklahoma to examine whether or not it's appropriate to integrate specialty care in there. How much of it do we need? And you might do a provider needs analysis, but tying it to that CHNA is a really key component of figuring out what is the best way to have, what's the best way to actually deliver this care. Sometimes it's going to be, hey, there's another practice in town that we can align with, that we can have a partnership with to be able to provide this care, right? Like if there's an ophthalmology practice or a dermatology practice that we can have better coordination with. Sometimes it's going to be something that we're going to have to build, right? We look at our CHNA and we need to have our diabetes incident is really high. We don't have access to endocrinology. It's all falling on our family practice providers, but the level of what we're dealing with probably needs to have some access to an endocrinologist. So how can we actually bring that into our community? Do we have to be able to build this practice through employment? Is there a way that we can purchase this service from an affiliate partner or somebody nearby? And so actually going through and looking at your CHNA and understanding what your disease incident rates are, understanding what the different socioeconomic and social determinant of health issues that your community has will help you figure out what the appropriate complement is within your RHC. And understanding then, of course, you would still want to do a financial feasibility of like, okay, how do we best integrate this into an RHC and then make sure that this is going to actually be financially beneficial? If it's something, because I will say that financial feasibility analysis will help you determine what's better of like, do you need to buy, build, or partner, right? Don't just assume that, hey, my CHNA says we need to be able to have access to cardiology. Don't always say that it's up to you to build the cardiology. Is there a potential partnership if it's not the most financially feasible option to put them within the RHC? So figuring out what is the right place to provide that care, if it's within the RHC, if it is elsewhere. And that's part of actually doing the best practice of thinking about things really strategically and forward looking, as opposed to oftentimes, and especially I will say, given that we've been in this COVID trauma vortex of just trying to be on a day-to-day survival mode, is trying to get back to that strategic planning, going back to thinking out, hey, what do we need in the next 3 years, 5 years, et cetera? Because a lot of these programs take that time to develop, right? And to be able to get all the different ducks in a row, and especially if it means expanding your RHC or doing other outreach clinics, I think that's really an important part of that, to figure out, hey, maybe it's a stair step of we're going to have a partnership and have those kinds of arrangements for the first couple of years, and as it grows, maybe we should expand that to something that's a more permanent placement or expansion of a service. So talking about, I want to shift gears a little bit, Amy, if you don't mind, is talking about the RHC methodology. Like, we had that big change to the new reimbursement methodology, and with that change, I know it was very beneficial to especially independent RHCs who might have been only getting like $83 and the $83 rate, and now have access to additional rate. What would you say under the new reimbursement methodology, what would be best practice for an RHC to make sure that they can still maximize their all-inclusive rate potential, Amy?
Opal, what I would say is to really understand what a qualifying visit is and how it's defined and what the differences are between them. That would be the key piece that I would look at. That within that RHC visit, it's defined as a medically necessary medical or mental health visit, or a qualified preventative health visit. And so a patient may show up, and when they come in, they're like, I'm here for my annual wellness visit, but I also, I've been feeling a little sick. So can you, check out to see if I've got a cold, the sinus infection, something going on. Well, both of those visits treating the patient for their annual wellness visit and treating the patient for the illness that they are feeling, both of those fall on the list of being qualifying visits. However, our rural health clinic will only receive a single payment for that service. And so, it might be advantageous for the clinic itself to say, I know you're not feeling well today. What if we reschedule your annual wellness visit? You can come back next week when you're feeling better. We'll treat you for that. And we'll see you today for this illness that you are feeling, and to really be aware of those services that are happening. Because if you schedule it, 2 weeks later, that annual wellness visit, the clinic could receive the both payments for both qualifying visits, one today and one in 2 weeks. So that's what best practice is to do that. Now, I say that, and I know you and I have had some discussions back and forth about, but Amy, you've got to balance, what's best for the patient. There are times, though, that the patient does not have transportation options, and those options are limited, and the patient can only get there in one day. And those are times that the clinic needs to just recognize that, in this instance, we're only going to receive that single all-inclusive rate payment. And how do we maximize that? And a lot of times people are like, well, what qualifies as a qualifying visit? What falls on that list? And there is a list of 400 CPT codes that you can go out and look at and know that these procedures are considered that. And then looking at scheduling and be proactive in just how you are scheduling those services. Do you need to say, this one can be treated today and that one may be treated on a different day? But there is, the exception to that is if a patient is seeing a medical practitioner for services and then they have a mental health visit. Those are actually two items that can be done in a single day and receive two all-inclusive rate payments because they're treating the medical condition as well as the mental health condition. And those are just areas to look at
Now,
and
Amy,
focus
so
on.
you brought up something that's really interesting because we were actually having a conversation with NoSOR about this recently. Is that focus on in an RHC of really understanding the separate billing for chronic and transitional care management, of making sure that they're actually figuring out how to properly document this to make what goes into the all-inclusive, what is not, because that there's so many missed opportunities for both chronic and transitional care management, that this is actually probably an opportunity that RHCs have. Like, so you mentioned, hey, here's how we might want to separate out this visit for maximized reimbursement. But I would say one of the bigger opportunities, maybe, and I don't know this for a fact, but one of the things that we've seen is going through with a patient. That if you know a patient, when you're doing your chart prep and looking at the week and doing your huddle of figuring out which patients are going to be there, are there patients who are coming in where that chronic care or transitional care management could be done while they're there, since you already have a patient coming in? Because if you want to optimize the for a patient when it comes to revenue, is making sure the patient gets in the door to begin with. But while they're there, what is the scope of services that they need, and making sure that you actually do that entire patient care management, looking at their entire chart. Do you have policies and protocols in place to examine that, so you don't miss out on the opportunity of, hey, I've got a live patient here. Is this an opportunity to talk about their chronic care or transitional care management that it just so happens you can also bill for that as well?
Right. And Opal, the thing that's also interesting about managing these visits is there are services that are your preventative visits. And when the preventative visits are out, when you have the preventative services, certain lab tests are considered preventative and such. that when you have those, there's no copay or deductible attached to them. And so the patient doesn't have an out of pocket, that 100% of the payment would come from Medicare for those. So that's also a way that you could just really leverage how the claim is being billed, how you are looking at the services that are being provided to receive that full all-inclusive rate payment from Medicare, a payer that's going to pay you, rather than having to chase the patient for the copay or deductible. And really, one of the areas that I always focus on is, what is the impact to the community? If you can say to your patient, this is what the reason we are doing this is because it's a financially beneficial to you to have this done in this specific way, because you won't have a copay or deductible for these services and things like that, and really leverage some, how those rules work, and explaining to the patients and helping them understand the why behind why you're bringing them back a certain day, or while you're actually treating them today, just what's beneficial to your patient and to the community itself.
Yeah, you definitely don't want to miss out on those patient education opportunities when you
Mhm.
can.
Exactly. So Opal, we're coming up to the top of it, and the final question for you is, what's one key takeaway from using RHC data that will help drive outcomes for the clinics?
So I'm one of those people that, data is everything. Like data driven decision making is really, really important. And going back to the staffing question that we were talking about earlier, is actually, I know we don't have enough staff, and we're oftentimes the training that we're having with our new staff is that they're shadowing somebody for a day and then they're kind of on their own afterward. But one area where I think we actually do need to go ahead and take the time to be able to do the training, even if it means slower and being less efficient during that training period, is when we promote somebody into a leadership position and do that kind of decision making. Like we've all been there. We've had our MA that has worked in our clinic for a number of years. Our practice manager retires, and so we take the MA or the LPN that's been working in the clinic for the longest time, and they get promoted to practice manager, right? And when we do that, we don't actually necessarily give them a lot of leadership training. And oftentimes they here's your new role, here's your responsibilities. You're somebody that everybody in the clinic respects and trusts. And we give them very much what I would consider more supervisory things. It's like, hey, you're in charge now of making sure the schedule is full. If somebody calls in sick, like figuring out how to adjust the schedule. You now have some budgetary responsibilities. And we kind of leave it at that. And we don't really teach them how to use data and how to do some data-driven decision making. And really, if you want to drive your outcomes in your practice, especially your overall financial outcomes and your profitability and your throughput, you really do need to have it based in some sort of data. And the people then who are utilizing that data need to be trained in that data. And so realistically, it kind of starts even foundationally of, all right, what is the data we use and how frequently is it reported, right? What's the cadence? Where do I get the information? And, for the people who are new in leadership, I would say it even gets down to the fundamentals of, do they understand what are the overall organizational strategies and goals? Where does the RHC even fit within the broader organization? And so if they understand, like, here are our key objectives for the organization, like this is the 5-year strategic plan for the organization, and here's where the RHC fits in with that. And here's the data that, that is important for you to engage with to understand whether or not is your location moving the organization forward? Is it actually achieving the objectives that we've outlined for it? Is something that, frankly, a lot of places we just haven't had the time to do. And it feels like that to do that comes at the cost of how we're running the clinic, and we don't have administrative time, dedicated for the people who are leading our clinics, are still working full time, rooming patients, and doing that. But that kind of training is really important for them to then focus on overall, what is the practice's performance? Oftentimes it might be the first time that they actually have to think about their engagement with the physicians and the APPs in a completely different way. Now they're now having to engage with them about financials and dashboards and this kind of information that they may never have. They may now have a physician or an APP coming and asking them about work RVUs, which they didn't have to worry about before. And so you have to make sure that they get the opportunity to have that proper training about the dashboard. And I have on here a list that we provided previously about, when it comes to an RHC management, here are some different numbers you definitely want on your finance and operations dashboard. Given that we don't have this endless amount of time to put somebody through some sort of, RHC manager training course that they can spend, 3 months learning before they actually get started in their job. And instead what we're dealing with is on the job training. Is I like to pick, let's just pick one metric to work with them on for a period of time. And then let's add another one. They may still get the full dashboard, but actually spending that time working with the finance department to go over, hey, here's the days in AR and here's what it means. And here's how the practice is actually performing in this. And so that the person can actually think about, all right, what are we doing within the RHC itself that's impacting days in AR, right? What is our current collection rate here at the front desk? Are we getting in all of our co-pays? Are we making sure we're doing the cash reconciliation every night? What do I need to be watching for on my front desk people to make sure that they're doing things properly now that I'm in a leadership position? So just taking any one of these individual metrics and doing some additional training on that, and pick a metric a month until they've really got their dashboard down of understanding, because that's also how you start teaching them to do data-driven decision making, is they can start looking for trends in the information. And that gets them to be curious about, hey, I'm seeing this change. My visits and work RVUs per provider have dropped. What's going on with that? Let me examine my no-show rates. Have we had a transportation issue recently with, it's starting to get, when it gets colder, we had too hot of a day where people couldn't walk to the clinic. That we've definitely seen that with many of our clients, where there's different things that are impacting this. But if they're not looking at the data and they're not trained to look at the data, then they're going to have an issue with being able to make decisions, and it becomes very, very subjective. So I would say that, if they want to drive outcomes, it really needs to be based on good data, but that you have to train your team to utilize that data, engage with it. And if you say you have good leadership that is actually already trained in this, it doesn't hurt you to start training other staff who are not in leadership. That's part of how you engage with the overall staff about doing process improvement. Is, Kate was talking previously about getting ready for a survey and such. If you're having, the things that Kate was going over as far as some of the top 10 areas where people were still being really deficient in, hearing that, hey, having them go through and review that dusty binder that has all of the policies in it that nobody's looked at in a while, talk to us about what the sterilization of the instruments and what process you go through, and assign that to them and be like, hey, how many times, separate from the sterilization of instruments, of how, can have them do the inventory of opened and dated single dose vials, and have them figure out what process do they want to make sure that that's not happening, right? Give them a problem to tackle that is putting your RHC potentially at risk. And the more you can engage staff with that, then you end up having a really cohesive team that is looking constantly for data, and they have that curiosity about them. So, Amy, that's what I think about when I think about driving those kind of outcomes and kind of pulling all of this together and all the things we've been going over so far this year with the RHC.
I agree, Opal, and a lot of those items out there are revenue cycle items. And, that's how you just monitor the performance, the financial performance of your organization, as well as with the ones that are operational in nature to, how it's operationally working. So we are 5 minutes before the top of the hour, and I just didn't know if anyone in the field, if there were any questions from anyone that's listening, if you want to just submit them real quickly to us and we can see if we can address them. You can send it either via chat or just take yourself off of mute, whichever you prefer.
Hello, can you hear me?
Yes,
Yep.
sir.
Hi, my name is Nick Fletcher. I'm submitted the first question you guys addressed, so I thank you for that. I was just curious on listening to the conversation around RHCs, because I just am, like I said, I am new to all the talk and the information. What is the average size of an independent clinic participating in RHC in Oklahoma, or anywhere for that matter?
I was going to say, I don't know, I mean, I don't know if Laura has it, but I don't know Oklahoma's specific numbers. I will say for RHCs overall that we work with on the independent side, I'm usually seeing probably, I would say 4 total providers, 1 physician and 1 APP. As far as the independents, I mean, there's definitely some much larger ones, like the Robert C. Byrd Clinic is a great one in West Virginia, and they are very large. But I would say the majority that we work with are probably a little bit on that on the smaller size. And there's a lot that are just frankly solo practitioners who have learned about RHC opportunities and have gone after that. So I think there actually is many out there that are just a single provider, maybe 2 providers. But on average, the number that we work with, I would say, are probably in that 3 to 4 provider size.
Okay, yeah, that was my.
Yeah, Kate, you probably know better.
Yeah. So we work, of course, across the country, just like Stroudwater does. And we see many single solo providers, onesie, twosie kind of clinics just getting started. And then we see 30-room clinics, which are fascinating that it's in rural, so it really runs the gamut. But I would agree with Opal. The average is about 3 or 4 providers. I think that would be a good number. But you can do it either way. You just have to remember from the results of this, you gals did a great job on your presentation. The moving parts in rural clinic are many, and it's quite a stretch for a single NP to pull this off. It's a lot, but it can be done. It's done every day. So we'll help you, and Opal and Amy will help you.
Yeah, Kate, I love what you talked about as far as, I answered that question initially of saying, hey, once you get it all in gear, to me, it doesn't have to be more work than what I would consider best practice of just how I would operate any practice. But if you are nowhere near best practice, it initially is going to be significant work on that front end, but it's work that you almost every single time better off doing to get you to best practice and frankly a far more financially sustainable future than to continue as is with that and not doing that big hurdle.
Right.
Thank you.
Absolutely. Thanks for the question. And good luck in your being new to this. And if you have future questions, there's our contact. All 3 of us would be happy to have any follow-up conversation with you if you just want to brainstorm about some stuff that you're dealing with.
And Opal, I was going to say on that note, Opal, I really have a strong, I really want to support the rural health clinics that are out there and help them understand and navigate through these waters, because it is different. And because you're in that rural setting, it can feel very lonely, and we want, to feel like that you're not alone in this venture, that there are those of us who are working with others who are in the same similar setup, and, we can form a community and really support each other in that. And I appreciate, Laura, for you setting up this network of the RHC clinics in Oklahoma. I think that, it helps to just sustain the initiative and helping the people in Oklahoma And, you know, that's really what we all want to do.
Well, thank you all. Real quick, we have about 1 minute left. I just want to check and see if there are any other questions that folks had that they didn't get to ask earlier. All right, well, as you leave this call, if you get to your back to your desk or start working on something else and you're like, hey, I have a question, please feel free to reach out to me. I'm happy to get in touch with Amy, Kate, or Opal. And please let us know if there's anything we can help you with. I might have mentioned at the beginning of the call, this is kind of, we're wrapping up our Flex grant year. And so August 31st is kind of that deadline or the end of that year. And so September 1 is our new year. And much like the other webinar series we've been doing, we're looking for new topics to start our next year. And so if there are any RHC specific topics or, hey, I want to learn more about this, please send them my way, because we are trying to line up some webinars, some education for the next year. So with that said, thank you all for your time, and everyone have a great day.